Welcome to ASCP's Best Practices in NSCLC Biomarker Testing video conference series. Today's session focuses on implementation of CAP IASLC AMP 2018 molecular testing guidelines. My name is Dara Oken, and I'm a learning experience designer at ASCP, and I will be facilitating today's session. This session is developed through a commercial sponsorship from Genentech. This ASCP Genentech initiative is aimed to support anatomic pathology managers and their teams by building community and providing effective resourcing to drive biomarker testing continuous quality improvement on behalf of patients. Please note that this video conference is being recorded, and by participating, you are agreeing that ASCP may use the recording of your image and statements on ASCP's website. So before we start, let's take a moment for introductions. Please type in the chat your name, title, and institution. Great, nice to see people coming in. As you introduce yourselves in the chat, let's do a quick recap of where we started to get to this point. Our first video conference in the series, which took place in November, was standardizing protocols for optimal procurement, fixation, and tissue cytology rose specimen handling with Dr. Lani Armis and Dr. Zara Maleki, both from Johns Hopkins. The second video conference in January was actionable results and turnaround time indicators for NSCLC workflows with Dr. Michelle Schiller and Ms. Kimberly Brinkley from Path Group. Recorded highlights from both presentations are in our Facebook group and Resource Hub. We encourage you to explore and respond to the questions that are posted as a way to share and learn from others. In addition, if you missed the previous sessions and would like to watch the videos in full, you will find YouTube links at the ASCP Resource Hub. As our emphasis is on application, with the focus on the perspective of the lab manager and their team, we split into breakout groups to address challenges and potential solutions. So these word clouds illustrate the topics discussed by participants in small groups. We've also developed an action plan as an individualized companion component to the video conference series to assist you in improving your NSCLC biomarker testing processes and workflows with a path for attaining your patient-centric goals. This document is intended to help you define your goal and steps to get there, to explore barriers and ways to overcome those obstacles, all while being able to track your progress toward your goal. In the chat, you'll find a link to the action plan, and we will also provide the same link in the post-conference survey. So today we will hear from Dr. Paul Vanderlyn, Associate Professor of Pathology at Harvard Medical School and Director of both Thoracic Pathology and Cytopathology at Beth Israel Deaconess Medical Center, and Dr. Praneel Chandra, Chief Medical Officer and Vice President of Genomic and Molecular Pathology at Path Group. First, Dr. Vanderlyn will share considerations regarding the guidelines, CAP, IASLC AMP compared with NCCN in the context of the rapidly changing testing landscape with updated FDA approvals. Dr. Chandra will follow by discussing implementation in a large-scale community practice, and we will have a brief Q&A following the presentation. Finally, we'll separate into breakout rooms where you'll have an opportunity to actively participate in a whiteboard discussion related to applying best practices, and we'll capture highlights of the ideas generated for the Resource Hub, as well as continue the discussion in our Facebook group. A few final reminders before we start. Please keep your microphone on mute until you raise your hand and are called on to speak during question times. And also, please do not share any protected health information or personally identifiable information about patients. So now let's welcome Dr. Vanderlyn and Dr. Chandra to share their slides and begin.
Great. Thanks, Dara. Really appreciate that introduction, and thanks to everyone for the opportunity to talk to you very briefly this afternoon about different guidelines that we have and some of the factors that we have to think about for molecular testing in non-small cell lung cancer. And as shown before, these are my disclosures, really have nothing to do with what I'll be talking about this afternoon. And so, as we're all very aware, the landscape of biomarker testing in non-small cell lung cancer really has changed dramatically over the past decade or so, with multiple gene targets being identified that have approved FDA therapies. And so it's been really gratifying over the past decade to see this pie chart filling in with different subgroups of non-small cell lung cancer that can be treated effectively with targeted therapies. Keeping in mind that there are emerging and evolving therapeutics coming down the pipeline as well. And so you're thinking about why is it so important to do this biomarker testing. It may seem very obvious, but really study after study has shown that compared with unselected cytotoxic chemotherapies, if you can identify those tumors that have actionable targetable mutations that can be treated with a specific drug, usually a tyrosine kinase inhibitor, those patients have an improved response rate, they live longer, they have an improved quality of life. And so really the onus is on us in the pathology laboratory to make sure that we match those patients with the most appropriate therapy that's most efficacious and has the least toxicities. And so to really help guide us in making these decisions, there are a number of guidelines that we're all familiar with that have been put forth by professional societies. I think most of us in the pathology world are most familiar with the CAP IASLC AMP guidelines, which is really the focus of the talk today. That's been largely endorsed by ASCO. But I'd also like to bring to your attention the NCCN guidelines, and we'll talk a little bit about them as well. And so the CAP IASLC AMP guidelines first came together in 2013 as basically a joint effort by these professional societies looking at helping us understand when to test, what specimens to test, how to test, and what targets to test. This came out in June of 2013 and was updated 5 years later, came out in March of 2018. That really is the foundation of what we have been doing in the pathology laboratory. And in addition to giving us instructions on what to test and turnaround time that has been discussed in previous sessions, really the focus largely is on what to test. And so in 2013, we really only had EGFR and ALK to test. In 2018, ROS1 was added on as another biomarker. And that's really where things stand right now if we adhere to the most recent 2018 guidelines. But unfortunately, that's terribly outdated. The good news is that the third edition of the CAP IASLC AMP guidelines are in the works right now. They are being, the working group is being brought together and the guidelines are being revamped. And I have the pleasure of being on the advisory panel for this. And we have a target publication date of about 2023 for this new updated CAP guidelines. And so something as AP managers, you should always, be well aware of what's coming down the pipeline and what will we be seeing. And really the strength of these CAP guidelines is the deep dive and the depth of the work that goes into compiling these guidelines, including the advisory panel, the systematic literature review with detailed data extraction, evidence grading, the drafting of the recommendations, and then the open comment period and the peer review. So this is a very in-depth process, but again, unfortunately takes up to 2 to 3 years from start to finish, from when the process is initiated to when the guidelines are actually published. And that's really a lifetime when talking about non-small cell lung cancer. And so really, if you're not already attuned to the NCCN guidelines, so the National Consortium of Cancer Centers Network, it's 31 cancer centers in the United States that really have come together to also put forth guidelines on the management of multiple different diseases. And for the non-small cell lung cancer, we talk about in these guidelines the surgical approach, the oncology, the radiation therapy, diagnosis, as well as the pathologic management. And I bring this to your attention because since 2018, there have been 29 updates to the NCCN guidelines that have been published over that period of time. Again, really reflecting how up to date the NCCN guidelines are and the rapid pace of change that happens in this field. And so, in contrast to the 2018 CAP guidelines, where really they say the only three that you have to test are EGFR, ALK, and ROS1, at this point in time, the NCCN guidelines recommend at least testing for 9 targets: BRAF, MET exon 14 skipping mutations, RET, NTRK fusions, GRAF, the KRAS, the G12C, as well as PD-L1 status by immunohistochemistry. And then if you also include the pan-tumor biomarkers, including MSI status and tumor mutation burden, there really are up to 11 targets that need to be assayed. And so again, as AP lab managers, what do we do? How can we make systems to ensure that we have effective genotyping done for all of these non-small cell lung cancer specimens? Now, as what Dr. Chandra will talk about in the next talk, unfortunately, this biomarker testing is very broad, and there really is no single test that will capture every single one of these biomarkers. And I put up on the screen here a pictorial representation of the different modalities of testing that can be employed and highlighting their strengths and weaknesses. And so, even though there is no one single test that will capture every biomarker, really the way that the field has moved is really towards large panel-based next generation sequencing based panels, and again we'll hear a little bit about that momentarily. So other than knowing what's coming down the pipeline, other than knowing about the NCCN guidelines, which again are updated at a much more rapid pace, what else can you do as an AP lab manager to maybe have a sense of what your oncologist, what your pathologist will be needing going forward? And so, and another thing to kind of keep a pulse on what's going on is to look at the FDA drug approval page, and I put the link down here. And this is something that I check on a monthly basis as well. So if I'm not told by my oncologists what FDA drugs are just approved, I can look and see if there are any drugs that impact the areas of pathology where I study. And this is really important because once there is in the United States an FDA approved therapy for a particular type of cancer, for a paired biomarker, that is really what will drive the need for testing. So the FDA approvals, again, are basically the downstream effect of those clinical trials that are being done. And so if you know what drugs are approved, you can anticipate what testing requests will be coming across your desk very soon. So in summary, my very brief part is that in non-small cell lung cancer testing, really the ancillary or the molecular testing has become central and key to directing oncologic care. And our oncologists cannot make the decisions on how to treat these patients until they have that testing result back. The guidelines, the CAP guidelines, are extremely useful, but also the NCCN guidelines are useful in helping direct what, how, and when we should be doing this testing. And I would encourage you to keep an eye on updates and new biomarkers so you can anticipate changes in the laboratory. And truly, the success for testing is a team approach. And here in pathology, the pathologists, the send-out teams, the molecular laboratory really all have to work in concert with our clinicians, really to make a system to understand, what tests to order, whether we do in-house testing versus send-out, how to order the testing in your OMR or lab information system, and how those testing results get reported. And on that note, so I'll hand the microphone over to Dr. Chandra, who will be touching on a number of these different aspects to the testing paradigm. Thanks.
Well, again, thanks for teeing things up for my presentation, Dr. Vanderlyn. That was a superb job. And over the course of the next 15 minutes, before we do that, these are some of my disclosures you can see here. And over the course of the next 10 to 15 minutes, I'm going to talk about our perspectives on how to implement molecular testing in community practice. And so before I do that, I wanted to just give you guys a background about our practice and the practice where I'm at. And we are a very regional, community-based practice that serves as a regional molecular reference laboratory. So our physicians serve as medical directors at over 150 hospitals that are part of integrated regional healthcare systems across a number of different states. So our implementation is a little bit more complex and varies from institution to institution, but we have some overarching principles that we like to apply and collaborate with local pathology leadership, local AP managers, as well as molecular managers wherever appropriate. So the one thing I wanted to emphasize is that we have a very collaborative and educational approach to implementing testing. And so when you look at the different types of tumors that can come across a pathologist's desk and the microscope, there are a number of different molecular tests that can be ordered. And so our educational efforts, again, it starts with education and it also ends with education, is making sure the right test or right series of tests is performed for the right patient at the right time. And in the context of lung cancer, as Dr. Vanderlyn pointed out, it is extremely, extremely important to try to consolidate testing into next generation sequencing panels, because there are a number of targets that are critically important in the evaluation of patients with advanced non-small cell lung cancer. And single analyte tests today, in today's era of molecular profiling, is just not enough to be able to capture all of those targets. So again, it starts with education, and it starts, and I'll show you how it also ends with education. But we have a very significant effort in educating our physicians, our AP managers, our lab operations leadership on appropriate test utilization and developing test protocols that are specific for the clinical as well as the histopathologic context. And so as Dr. Vanderlyn was alluding to, wherever possible, it's important to try to implement comprehensive next generation sequencing. Now, understandably, this cannot be done at many laboratories and requires volume and requires an appropriate business case. So there's always the option to send out testing to an appropriate laboratory. So I'm going to just give you our perspectives as a molecular reference laboratory and some of the reasons why we went down the route of comprehensive next generation sequencing. And as Dr. Vanderlyn mentioned, there are a number of targets. And so to be able to most cost effectively capture those alterations in those different targets, you have to start thinking about high throughput DNA, RNA sequencing and a panel that assesses for the diverse alterations in multiple, sometimes up to 100 genes at once. Why hundreds of genes? Why do we need to be looking at hundreds of genes? Well, you need a lot of genes to sequence in order to be able to report out a high quality TMB score. And so that's one of the reasons why we've now evolved to comprehensive panels. So it actually results in cost efficient utilization of limited tissue, and tissue samples can be very limited in the context of lung cancer. And the goal is to yield as much actionable information that is going to help drive therapeutic decision making, but there's also diagnostic and prognostic information that comes from next generation sequencing. It's important to note that it also requires a very significant investment into laboratory operations and other areas of the clinical lab in order to deploy comprehensive next generation sequencing. This includes capital investment into, it's not cheap. The instrumentation is expensive, as well as the reagents, and so you have to factor in those costs, as well as the costs of expanding your personnel. And so we have expanded our personnel to include personnel within NGS lab operations, and so this includes technical directors, molecular pathologists, as well as molecularly trained technologists, molecular accessioning managers. We actually have a molecular accessioning team that their goal is to coordinate test orders with the pathology team as well as with AP lab managers. And then obviously histology needs to look at their staff and make sure that they have a specialized team to coordinate with molecular pathology on slide preparation. And it just doesn't end at the laboratory. Client and billing support to make sure that all questions are answered, as well as making sure that the test is reimbursed. That's a topic that we can discuss further during the Q&A session. So I'm going to walk you through some of our pre-analytic, analytic, as well as post-analytic efforts, and I will step through some of these slides a little more quickly. So when there's an NGS test that's ordered by a clinician or a pathologist, in our institution, we foster pathology-driven test utilization that is actually shown to lead to improved outcomes and better utilization of testing, as well as improved time to treatment for patients. So that's important for you all to keep in mind. And so when the test is ordered, the appropriate slides are prepared. They are brought to actually the sample is accessioned by our accessioning team, and the slides are prepared by the anatomic pathology division and then handed off to the molecular pathology team that then proceeds to actually review the case, the clinical history. Is the test appropriate? Are we performing the right test for the right patient at the right time? If not, then we may make a recommendation for a test revision, and then that will go back to both the molecular pathology accessioning team and sometimes the AP managers as well. We will re-review the H&E slide and make sure that you have adequate quantity as well as quality of tumor. There's a certain tumor percentage requirement that you need to adhere to in order to be able to go and downstream in your next generation sequencing protocols. Is there adequate quality of tumor? The picture that I'm showing here on the lower right-hand side, this image over here shows a lot of tumor necrosis, and so that can be an inhibitor to the PCR. So these are things that the pathologist will take into consideration, and then they will outline an area of the tumor that is best suitable for next generation sequencing, and then we have technologists that will micro dissect that tissue for next steps, which I'll get into. The other question that comes up is, can the test be performed? And sometimes you have very limited tissue, and you may need to QNS the case, and that means rendering a report that says quantity insufficient, or you may need to cut more sections and get more tissue into your system, or you may need to fall back on single analyte tests because you don't have enough for comprehensive molecular profiling, but you do have enough tissue for single gene tests. So as you can see, it's a very complex process. There's a lot of effort by the physician, by the anatomic pathology division, as well as the molecular pathology division, to make sure that you have the right test, but also the right amount of tissue and DNA for downstream steps. So our analytic efforts include, as I mentioned, the tissue microdissection that is performed by technologists within the lab, DNA, RNA extraction, and then sequencing. After sequencing is done, we have a bioinformatics team that processes the data and all of the variants. I won't go into all the technical details, but that's a very significant analytic process. And then an initial report is rendered that's reviewed by a technical director and then by a physician, where the report needs to be integrative and highlights any diagnostic, prognostic, as well as therapeutic significance. Other things to keep in mind about the report that gets generated is the transmissibility into the electronic medical record. And so you have to design your report so that it is lucid, it's easy to follow. All of the information that comes out of your testing is right there, and it doesn't require a lot of time investment to understand what's going on for the patient. So that is another really important post-analytic step that we all need to be thinking about. You have to organize all of the information. Again, we're busy physicians, pathologists, and oncologists. And within 2 minutes, an oncologist really has to have a good understanding that here are the alterations, here are the therapies that I can utilize to treat my patient. So in addition to that, it's really important to support your local physicians as well as your local oncologists. And so we've actually set up email groups that are monitored 24 hours a day, 7 days a week for any questions that come back, or any questions on what do the results mean, test interpretation questions, or hey, I have a question about what test I need to utilize. And so can you help me with that? So again, it comes back to the education and engagement, where the pathology division, as well as the molecular team, as well as the AP team, we have to also continue to guide appropriate test utilization. And so some of the things that we've done is that we've created biomarker testing guides and protocols, and these are emailed out to our physicians, our pathologists, as well as our oncologists, and they are updated on a quarterly basis. As Dr. Vanderlyn pointed out, the NCCN guidelines is being updated very regularly, and so we have to also be on top of all of that and make sure that we're on top of all of the latest publications and get that to our laboratory operations staff, our physicians, as well as our oncology clients. We've also started running molecular tumor board series and interesting case conferences. And so these are live interactive discussions between pathologists, laboratorians, scientific directors, oncologists on the topic of, what do the test results mean? How do you utilize the test? And when is the most appropriate time to utilize these tests for patients with advanced lung cancers? So again, this is just a smattering of some of our efforts. It's a very complex process, and every institution is different. But it's important to know that the best practices for lung cancer biomarker testing, they are evolving very rapidly. And this does require building an appropriate lab operations infrastructure to address the pre-analytic, analytic, and post-analytic efforts that are necessary to provide comprehensive genomic profiling or molecular testing, whatever is specific to your institutions. And in that role, laboratorians, pathologists have a really critical role to play in making sure that the right test is performed for the right patient at the right time. And this team that is necessary includes molecular pathologists, surgical pathologists, operational lab managers, AP managers, molecular pathology managers, and local care teams. One of the things that we're now starting to implement is actually monitoring test utilization and then continuous education. So it's kind of a coming 360 degrees. Starts with education and it ends with education, and it's a continuous process that also necessitates making sure that our institutions are utilizing molecular testing wherever clinically indicated and appropriate. So again, that concludes my presentation, and I wanted to thank you all for your time, and we'll be happy to take questions. Dara, back to you.
Great. Thank you, Dr. Chandra and Dr. Vanderlyn, for phenomenal presentations. Let's move into questions. In the chat, I see something from Oana Roska. Are you receiving unstained slides or tissue blocks? And how quickly do you give feedback on the appropriateness of testing and or tissue adequacy for molecular testing?
Sure, I can feel that. We either utilize blocks or unstained sections. The block is preferred because in lung cancer, it is pretty frequent where we need to go back and cut additional sections because the original tissue sample is very limited. And then as far as how rapidly do we give feedback, if there's insufficient tissue, that report is signed out within 24 hours because that needs to be communicated to the originating facility that you don't have enough tumor and you may want to either send us another block or additional unstained on another block, or the patient may need liquid biopsy or maybe a sample from another biopsy. So again, it's really important to make sure that you're communicating all of that in real time as quickly as possible.
Wonderful. I see another note in the chat that a few people are very interested in getting on your mailing list of your interesting cases, which is wonderful to see. Also, what is your cutoff for tumor content, 10, 20%?
So happy to feel that as well. And Dr. Vanderlyn, please jump in if you've got additional comments. We require at least 20% tumor, and ideally 5 millimeters by 5 millimeters by 5 millimeters of tissue. When we have that much, then we've seen in our practice that there's a greater than 90% chance of success in completing comprehensive next generation sequencing.
Yeah, and obviously, more tumor better, is the key. And some things that I'm sure that many of the AP practices, represented here are doing, upstream of the molecular laboratory, actually in the pathology report, indicating for small biopsy or cytology specimens, what is the tumor cellularity? Is it, what is the tumor content? Something very good to have so that you can even prevent the wasted time, so to speak, of sending a suboptimal specimen to the molecular laboratory when, again, turnaround time is so important. And you want, if you know you're going to need another biopsy, you can maybe head that off at the pass. And so, and then the other point I wanted to make there is that obviously you do need, minimal amounts of tissue input and tumor purity for NGS testing. If you have specimens that might fall below that, it might be adequate for immunohistochemistry, where you can do more of a limited workup or a focused workup, again, depending on what the clinical scenario might be.
Great. Here's a follow-up question related. If you have less than 20% and there is no alternate tissue, do you still try NGS or just recommend liquid BX?
So if there's less than 20% tumor, then unfortunately, that wouldn't meet the cutoff of our assay. And so that would be a case that we would likely sign out as quantity insufficient and recommend either another sample from another location that has more abundant tumor. And then the second thing to consider is liquid biopsy testing. And so that's another type of test that assesses for mutations in peripheral blood and is now being recommended by NCCN guidelines when tissue biopsy it does not yield anything, or the patient is not in a clinical state to undergo a tissue biopsy.
Yeah, and with that, our oncologists here locally have really been using the liquid biopsy in tandem with tissue biopsy, and the Achilles heel of a liquid biopsy is the same Achilles heels if you have a paucicellular or a tissue biopsy with less than the 10 to 20% tumor cellularity. It's great if you actually find a genomic alteration, but the problem is you run the risk of a false negative result, right? And so oftentimes we're limited by what tissue we have and how difficult it is to get that tissue. But the use of liquid biopsy and understanding the risk of a false negative is something that you have to worry about for those borderline specimens.
We have time for one more follow-up question before we move into our breakout rooms. The follow-up is, do you have algorithms for molecular testing in place?
We do. And so the way that we approach this in my institution, again, we have over 100 hospitals where pathologists, either our own pathologists or pathologists from another institution, are actually directing the local hospital laboratories. And so we have kind of an overarching recommendation that comes out from the Central Molecular Division here in Nashville. And we base our recommendations on what's recommended by a variety of guidelines, including the guidelines we talked about today. And NCCN guidelines are a very important part of that. And we basically take all of those recommendations and digest them down into, here's what we recommend. That's handed off then to a local laboratory medical director and the local AP management team at that institution, where conversations ensue and then local decisions are made. So that could be adopting, what we've recommended, modifying what we've recommended, or simply coming up with a local institution specific protocol.
And just very briefly, so the algorithm here has actually gotten very simple over time, even though the number of biomarker test targets has exponentially increased. So really, pretty much every non-small cell lung cancer here gets PD-L1 immunohistochemistry plus broad-based NGS panel testing. That NGS panel will catch everything, that is needed for FDA-approved therapies for clinical trial inclusion, tumor mutation burden, co-mutational profile, and that's really the information our oncologists want. And so really it is NGS plus PD-L1 IHC as the algorithm right now.
Great. Thank you so much for this informative discussion. We're actually going to switch into our breakout rooms. We have a short time for this. So you may remember the point of thought question you received leading up to today. Is your AP lab trying to implement testing guidelines? What's working and what's not? This is the opportunity to learn from each other. And as you see, we have a visual framework with guiding questions, which will support your discussions. There will be an expert discussion lead in your group to walk you through the process. And you will be able to participate simply by typing your comments, which will go on sticky notes as you see here. This way we'll have an anonymous record of all the ideas shared. In a moment, you will receive a prompt to enter your breakout room, and when time is up, you will be redirected right back to the main room. I hope you enjoy your discussions.
And for those of you who have stayed behind and are not yet in a breakout room, I'm just going to zoom in on some things that are happening in the breakout rooms in case you'd like to follow along and see what's being discussed. And it looks like the first group is talking about whether biomarker test orders are available at their institution and creating sticky notes to indicate the types of orders that they're doing, such as NGS, panels, single genes. And it looks like the second group is also having the same discussion. And they're starting to discuss how the biomarker tests are ordered. Paper orders, reflex testing. Who's determining the biomarker assays that are ordered? They're starting to discuss that NSCLC biomarker testing guidelines that they're following. Let's see how group 2 is doing. Looks like they're starting to discuss question number 3. And that's what biomarker processes are the most challenging. This is being discussed in the breakout rooms right now. Let's see how group 1 is doing. Challenges measuring adherence to guidelines. Specimen size being the major issue. Multidisciplinary teams and turnaround times. Specimens coming from eBus that are always small.
As people are coming back to this main room, this has been a phenomenal sharing session. It is so exciting to visually see your ideas, your sticky note input. We unfortunately will not have time to debrief each and every one of these graphic organizers, but we will invite you to view and comment on these visual notes, which will be posted in our Facebook group. And we will hopefully continue the discussion there. We do have one more interactive component that we are hoping to engage you on, and it's a poll looking ahead to a culminating event that will happen this summer. We'd just like to survey you on which of the following has the greatest impact in your AP team and lab operation. Please type in the chat 1, 2, or 3 numbers that indicate highest area of impact. Management of insufficient specimens, quality measures and continuous quality improvement, current best practice in biomarkers, reporting processes, internal versus reference lab testing, leading multidisciplinary change and improvement efforts. If you don't mind typing in the chat just the numbers that are most impactful on your AP team and lab operations. This will help inform the future sessions related to NSCLC biomarker testing. Thank you for providing feedback on this question. We have this question posted in the Facebook group as well. Hopefully we can continue discussion related to that there. Due to time, we will need to move to closing. We are now at the end of the hour and just want to thank you all for phenomenal participation, and thanks so much to the presenters for excellent sharing. We also invite you to save the date. The 4th video conference in this series will be on May 19th. Laboratory Information System and Electronic Health Record Implementation and Protocol Optimization for NSCLC. And in case you are wondering, we keep referring to the Resource Hub and the Facebook group. This is where you can access these resources, and with ideas fresh, you may choose to develop your action plan. Thank you again, everyone, and this concludes today's presentation.